Hi guys, it's Mona, and I am here with Dr. Aliabadi, and today we are talking all about endometriosis. This is a topic that's really common right now. A lot of women are suffering with. She is an expert on endometriosis, so make sure you watch the entire video through. We're going to answer all the questions you have and everything you've submitted on Instagram.
So basically, I always tell my patients, if you have painful periods, it's not okay. Let's start with that.
Okay, so you shouldn't have to accept it.
No.
Okay.
So the most common symptom with endometriosis is painful period. But a lot of our patients end up doing their pap smears with their primary care, most gynecologists don't have time to listen to painful period histories, and these patients usually are told that painful periods are okay. You can do a heating pack, you can take some Advil, stay in bed. I had a patient come to my office last week with a prescription for Percocet for her painful period.
Oh my God.
So instead of being worked up for that painful period, the gynecologist, who's a very well-known gynecologist in Los Angeles, gave her a prescription for Percocet. So
I have a question. How much pain is normal though in a period? Like what is it where you're like, that's okay? Is like a little bit normal?
So I use three rules in my office.
Okay.
If you go to the gynecologist for, let's say, your annual exam, and you bring up painful period, that's a red flag.
Okay.
I went to my gynecologist. I never brought up pain because most of us have a little bit of cramp. We
but
take
not
a couple
enough
of
to bring up. That makes
right.
sense. Totally makes sense.
Right?
Okay. Yep.
So that's the first red flag. The second red flag is if you stay home from work, from school. So I always ask them, when you have your periods, do you ever stay home, cancel your meetings, or not go to school, or skip some event? And if the answer to that question is yes, that's another red flag.
Okay.
And the third red flag, which for me is pretty much a stamp of diagnosis, is if patients say, I end up in the emergency room with painful periods.
Okay.
So I always ask them if they give a history that, yes, doctor, I've been to the ER 3-4 times. Was it during your period? Yes. So that's almost always endometriosis until proven otherwise.
Okay.
The problem with endometriosis is we do not have a blood test or a diagnostic test to just, do in clinic and diagnose patients. So it's a clinical.
There's no definitive diagnosis. You just have to.
The definitive diagnosis is surgery. However, it's a laparoscopic surgery where we put a 5mm camera through the belly button and we look around. I can't put a camera in every single patient that walks into my office and says I have painful periods, right?
Stick a camera in every belly button
before you walk in,
right? Right.
So for that reason, if you come to my office and you bring up painful periods, I just put you on birth control.
Okay.
I assume the worst and I treat. The reason is it's one of the most common causes of infertility. I always say that fertility doctors make their money on endometriosis patients. They really do. Because these are patients that, don't get treated in their 20s. Average age of diagnosis is 32, and on average, it takes 7.5 to about 11.5 years for these patients to get diagnosed. Part of the problem is endometriosis patients are very complicated,
okay,
and they require extra time in the clinic. Most doctors have 40 patients on their schedule, right? You cannot spend, let's be honest, with insurance companies, you can't spend an hour talking to someone about their painful period and having a plan for them. So what happens, these patients come in, the doctor has like 10 patients waiting in the waiting room. This poor patient is saying, doctor, I have painful periods. And he's probably thinking endometriosis. He just doesn't have the time to sit down and explain what endometriosis is and what the treatments are. So he tells the patient, here's the birth control, go take it. The patient goes home. The mom says, well, why are you on birth control? Who told you to? I heard birth control causes cancer. I heard birth control causes
bad. I heard, hormones
it
are
makes
bad.
you infertile.
Yep.
So what happens? They don't take it, but they don't really understand
that it's
how
important, and they should,
correct.
Maybe they just think it's going to help their pain, deal with the pain, and take Advil.
Right.
Okay.
So, because I treat so many endometriosis patients, and it's a bad disease. When you can't get pregnant and you're a woman and you want to start a family, I can't think of anything more devastating than that. So that's why endometriosis has become my passion. And one thing I've learned over the years is instead of educating doctors and basically having them spend time and diagnosing and explaining the process to the patients and treating it, I've realized that it's easier to educate the patients. Because if you're a patient and you go to the doctor and you says, to your gynecologist, primary care, and you say, I have painful period, and they do give you a prescription for Percocet or Vicodin, or they don't treat you, or they don't have an answer for you, leave and go find the gynecologist who knows about endometriosis, who can treat you.
Right.
That will make a huge difference. If every gynecologist and every primary care knew about endometriosis and treated it in time, none of these patients would have fertility issues.
Now, does every gynecologist know, is it something you specialize in, or is it something
No.
that you just care to know more about?
I mean, I just treat a lot of patients. I've done this for many years. I have the luxury of having time to spend, with so when patients come in, that's one reason I don't take insurance, because I was also overwhelmed with patients, and I felt pressured that I wasn't doing my job right.
So when you're accepting insurance, they're only giving you a certain amount of time for each patient.
Right.
Okay.
So the payments from insurance companies are so minimal that doctors end up booking more patients in the hour, right?
Because then you have to make
sense.
right. You have to be
able to pay for your practice,
right?
So for that reason, I have the luxury to sit. I spend an hour with my endometriosis patients, because unless you understand the disease process, you won't go through the treatments. You won't understand why birth control will help, why an IUD will help, why suppressing your menstrual cycles will help. So that's what's important, and that requires a lot of time. And I think that's the problem with the system. The system fails. So
Right.
if you notice on TV right now, there are all these ads for endometriosis painful periods, because I think we've realized that if we educate patients, it's easier to get them help.
Because I think maybe it's like a rule, your doctor's there to help you, that's their job, but a certain percentage, at some point you have to take charge. So like
Of your own health.
right,
Absolutely.
they can maybe have a broad spectrum of what's going on, but you have to be the one to dig deeper, and you have to take that responsibility to do it.
So what I want to do today is I want to explain to your, audience, your followers, what endometriosis is, and if they have painful periods, I want you to watch this video to the end, educate yourself, and get treatment.
Yeah.
So basically, this is the model I use in my office. It's the female anatomy. This is the vagina. This is the uterus. Ignore all these fibroids in there, because I use it for other conditions too. So this is the uterus, 2 tubes attached to 2 ovaries. Just to make it easier for you guys to understand, from the day we get our period, which is about 12 and a half average, to the day we're menopausal, which is 51 and a half, our ovaries are trying to get us pregnant. So they secrete hormones, and they stimulate the lining of the uterus, which is this thin pink lining inside the uterus. So the hormones make this lining thick and juicy, ready for an embryo to implant. When we don't get pregnant, this lining comes out.
Yep.
This happens month after month, year after year. For reasons we don't understand, 10% of women, think about it, 10% of women in the world have this condition. That's pretty significant. So these endometrial cells are outside of the uterus, around the ovaries and tubes. So once a month, when the ovaries secrete hormone to stimulate this lining, these guys also get activated. They think they're inside the uterus.
Okay.
And when we don't get pregnant and we start bleeding with our menstrual cycle, these guys also bleed, but they bleed into our pelvis. So that blood causes an inflammatory process in the pelvis. Month after month, year after year, we start that chronic inflammation causes several problems. Number one, it can cause adhesions, right? So these patients start with, let's say, so that blood can cause pain, but chronic adhesions can also cause pain. So these patients first have painful periods, then it's 2 days before their period, then it's 2 days before and 2 days after, then it's a week before their period.
So it's like short term that builds to this like long term chronic pain.
Correct.
Okay.
And then they show up at 32, 34 with chronic pelvic pain. So adhesions, which is scar tissue in the pelvis, is one of the common problems. And number two, which is the most important thing as a gynecologist, is the egg reserve in patients with endometriosis that are untreated tend to go down faster than other women. So when you have a patient with endometriosis that's gone wild for like 15, 20 years, and you check an egg reserve, their egg reserve at 35 could be like a 45-year-old.
And this is when it's untreated. So there's hope. Right.
Oh,
Okay.
right. This is all untreated.
It's all untreated. Okay.
Untreated. That's why. So this is a simple way of explaining what endometriosis is.
Yep.
So when we start patients on birth control or hormonal, there are multiple different hormonal treatment for this condition. But when patients show up and they say I have painful period, that's why we say go on birth control. Low dose birth control can suppress endometriosis. But for patients with more advanced stages of the disease, then we go to stronger medications.
Okay.
Endometriosis is estrogen driven, so you don't want to give it too much estrogen.
Okay.
So we start with a low dose pill,
Mm-hmm.
but we also have IUDs called Mirena IUD. I don't know if you've heard of it, or Kylena is a smaller version of Mirena, which is very local, and it suppresses endometriosis locally in the pelvis, which works great for painful periods.
Wow.
In addition to that, endometriosis can also be in the lining in the wall of the uterus. When patients come to my office and say, "Doctor, I want a method of birth control," and in the back of my mind, I'm thinking she might have endometriosis because of her painful periods, I always recommend either a Mirena IUD, but now for girls who haven't been pregnant, sometimes with Mirena IUD, they get a lot of cramps for like a couple of weeks.
Just in the beginning?
At the beginning.
Okay.
So now we have a smaller version of Mirena called Kylena, which a lot of doctors don't know about this.
Okay.
It's a tiny Mirena IUD that when you put it in a small uterus, it doesn't cause any cramping.
Okay.
It's very well tolerated, works great for endometriosis patients.
Now, a lot of women are concerned that when you're doing something, IUD is an intrauterine device. So does it, when you take it out, are the hormones in your body longer? Is it the same as taking the pills or anything different?
As soon as I pull it, within a month to 6 weeks, you should have your period.
Oh, amazing. Okay.
As long as you started with normal periods. Right? So, but it's a great, great method of birth control for patients with painful periods.
Okay.
And it preserves their fertility. That's what I want them to understand.
Okay.
Patients who have painful periods, I get these patients in my office, they have painful periods, they haven't been treated, and I ask them when they want to get pregnant. Oh, another 4 or 5 years. No. You can't do that. So what we do, there's actually a blood test. It's not a predictive of fertility, but it's one of the blood tests we use. It's called AMH, anti-Mullerian hormone, is a blood test. Again, a lot of gynecologists don't do it. I'm paranoid, so if I suspect endometriosis, even at 25, I check an AMH, just because of the reason I told you, their egg reserve tends to go down.
Yeah.
So if at a young age, you have a low AMH and you have painful periods, then it's very likely that you have endometriosis, and egg freezing then would be an option.
Okay.
I usually start the conversation with egg freezing with my patients around 30 if
Okay.
they're not married. If you're not married and you approach 30, 31, I start having the conversation. It's very expensive. It costs on average about $10,000 to do egg freezing per cycle. So the importance of that is the younger you are, the more eggs and better quality eggs you put out. So basically you get more bang for your money.
I've talked to you about, because we talked about egg freezing around that age, and do you think it's just like a safety, if you have the money and if it's something you want to invest in, is it a bad idea to freeze your eggs just when you're 29, 30?
No, I have 3 girls. I'm going to freeze all their eggs at 28.
Why not?
Why not? If you can afford it. The problem with egg freezing is it's so expensive.
It is expensive.
When you're young, you don't have money to pay for it. And when you're older and you can afford it, your eggs are no good.
That's true.
So, but I want patients to know that there are programs in this country, for example, Care Credit. Basically, it's a medical credit card that patients are easily qualified for. Doctors pay the interest on the money. So whoever swipes the card will pay the interest. So if your fertility doctor is swiping $10,000, he'll pay the interest. And patients pay an interest-free monthly payment for over 2 years.
Oh, that's great.
Patients don't know that, but it's a great option.
Okay.
It's a great option.
That's a great option.
Patients who can't afford it.
Right.
But it's not as important for patients who are healthy and don't have endometriosis. But if you have painful periods and you're in one of those, you're 10% of the population has this, then I definitely recommend egg freezing earlier than later. And I check an AMH on my patients on a regular basis. Even if they can't afford it, I want to make sure they're not going down. But remember, if you suppress, then that egg reserve is not going to dive down.
I just think this is such an important topic, and I'm glad you brought this up, because so many women and people are afraid of birth control. And I mean, listen, I love anything holistic I can do, but at the same token, I'm not afraid of medication, because sometimes it's the right answer. If someone you think has endometriosis, birth control is 100% what you would recommend, right? I mean,
yes, but I tell them why, so they understand. Otherwise, they'll go home. Like I said, the grandma, the mom, the aunt, the best friend says, why are you on birth control? Your doctor doesn't know what she's doing. You're going to be infertile. And I always tell them, the patients that take birth control will never have fertility issues. The ones that have painful periods, don't suppress it, whether it's Mirena or birth control, or in more severe cases, you need, other hormonal therapy. Then you won't have issues with it. For patients who show up to my office and they have advanced stages of, their disease, they have endometriomas, which is basically endometriosis in the ovary, which we call it chocolate cyst. Those patients will require surgery before suppression.
Okay.
So,
and when you do surgery, that you can possibly that also lessens your chance of pregnancy, right?
No, not if you know what you're doing. Because we don't go zapping the ovary, but we actually zap all the implants that are in the pelvis as much as we can. We resect it, and then usually at the same time I put a Mirena or a Kyleena IUD while they're under anesthesia, and I don't have to deal with any of the issues.
While they're already under it.
Yeah,
that's true.
So there's so many options for these patients. The most important thing is to get to the point of diagnosis, which is taking doctors 7.5 to 11 years to diagnose.
Because after that 11 years, it's just building up so much where
it's
the pain,
irreversible.
And then finally, it's so painful where you realize it, and then it's a little bit too late. So I want to go through some questions some people asked, but overall, if a woman wants to know if she has endometriosis, if she wants to make sure she's preventing it, painful periods is the one thing. That's it? Is there anything else?
Painful period, painful sex.
Okay, that's good.
Usually it's associated with bloating. Good number of patients also suffer from, these are patients who get diagnosed with IBS, constipation, recurrent bladder infection.
Because they're feeling pain and they're like, oh, let's go to a GI doctor. Okay.
Right. Depression.
Wow.
It's in your head. We all have painful periods. You're being so dramatic.
Right. I've even heard that too, right?
Right. So,
women, go to a gynecologist. I think, you see a pediatrician until you're 18, right?
Right.
And then sometimes you just maybe think your general practice doctor can do your PAP. I would say, what age is the best age to start going to a gynecologist?
So that's a good question. Usually my rule is either 21 or 3 years after first intercourse, whichever one comes first.
Okay.
So if you start having sex at 14, then you come to me at 17, unless we need to do STD testing.
Right.
However, there are reports of patients as young as 8 with endometriosis. So even if I see teenagers with very painful periods, which is normal, by the way.
Right.
When you're young, we all had it.
We all had
very
it.
young. We all have. I've been to
the
nursing office in high school. It's normal for younger patients to have painful periods, but usually their painful period is associated with other symptoms. Nausea, vomiting, headache, mood changes as part of the PMS symptoms.
Right, okay.
Endometriosis patients is most of the time it's pain.
Okay. Not grumpiness, headache. So it's really
they can have that, but pain is their main concern.
Okay. One question that someone asked that I actually really want to address too is there's a lot of talk on endometriosis and beauty products and how people think that there's a correlation. And I think this is important to cover here because there is a lot of info on the internet and there is a lot
wrong information.
Exactly. There's a lot of bloggers, even just people that put out their opinion. And unfortunately, when you Google something, you can get anything. You can come up with anything. So as much as I'm an advocate for natural everything, it's not, I don't want you to beat yourself up and think that your skincare is what caused endometriosis.
No.
Like what?
So what we think, first of all, we know it's genetic. So if you have a family member with endometriosis, you're 4 times more likely to have it. If your mom had it, your sister has it, you probably will have it. Or if you have painful periods, then you need to suppress it.
Okay.
But we think what happens with endometriosis is during the menstrual cycle, you get backwards flow of the endometrial cells through the tube and into the pelvic cavity.
Okay.
And these cells then implant into the wall and can cause endometriosis month after month, year after year. That's why, which I think we're going to talk about this, PCOS patients.
That's next, yeah.
Have a higher risk of endometriosis because they get these irregular, infrequent, but heavy periods. So they shoot these endometrial cells into their pelvic cavity. So it's, I believe the number is about 40% association between PCOS and endometriosis. Again, something majority of doctors don't realize.
No.
So when your PCOS patient is complaining of also pelvic pain, it's good to suspect endometriosis in them. But once we talk about it, that's the treatment for PCOS is birth control anyways. So you fix both.
Okay. Really quick on birth control, is there anything, if you were to put someone on it, it's always low dose
I
estrogen?
start with the smallest possible dose.
Okay.
Certain birth controls for PCOS patients, they lower the androgens more than others. So for PCOS patients, I might pick a different one. But for endometriosis patients, usually you want to start with a low estrogen because remember, it's an estrogen-driven disease.
Right.
So you don't want to give them a lot of estrogen. That's pretty much it. But birth control pills are very safe. Obviously, we look at the patient's family history. If you have clotting disorders, if you're above age 35 and you're smoking, if you have a cardiac disease, if you're diabetic. So we look at the medical history to make sure it's safe. We don't just write a prescription for birth control for patients.
Okay.
But if they're, if they have any contraindication to combination birth controls, then we go to the IUDs, or different methods of suppression. But not suppressing endometriosis is not an answer. A lot of doctors operate on patients and let them go. If you have surgery and don't suppress it afterwards, 6 months to 2 years, you're back to square one.
Oh my God, so you have to, it's just a continuous thing.
Yeah, it's amazing how these doctors just operate and let the patients go.
And then you don't even actually have to maybe go through that operation. Like maybe
if you
can
suppress
just,
it
right,
early.
you can just suppress it.
That's key.
Okay.
That's why diagnosing it early is key, but because patients are not being diagnosed, my job, and I asked one of my patients, Halsey, she's been a spokesperson for endometriosis. I thanked her the other day because I can't make a difference. I can only educate my patients, I can educate people around me, but someone with her power can go on the internet with all her followers, or someone like you. Education is key with endometriosis.
And I think these messages are important because, like I said, we have to remember that medicine sometimes is necessary. And in this whole realm of natural wellness, sometimes you do have to go back to this, and it's here for a reason, and it can be here to help us. Right. That was one more question someone asked, was natural ways to lower estrogen in your body or to suppress estrogen. I mean, I don't personally know of any.
One that I can think of right now, weight loss. So patients that are overweight tend to have a higher estrogen level.
Okay.
So you need to lower it.
Okay.
And it helps. Especially, we'll talk about PCOS patients too.
Okay.
Weight loss can help them lower their testosterone too. So living a healthy lifestyle can help. But for endometriosis specifically, you need hormonal suppression. There's no other way around it. Please, if there's one message I send patients home with, is try not to treat endometriosis naturally. I don't care what blog you read, which website you go on, who's telling you, but I've been doing this for many, many years. I'm good at what I do, but there's no non-hormonal treatments available for endometriosis.
I'm a pharmacist. She's my doctor. She's brilliant. And I've known her personally, professionally, and she's, it's all coming from the heart and from such a good place. The moment I came here to this office, when you like something, you naturally want to share it. You just want to tell people. And I've always told people, you have to go see my doctor, because if you don't live in LA and you can't come here, I just highly recommend finding a gynecologist that you feel comfortable with, that you can tell actually cares. Sometimes it's not in the biggest office. Like maybe sometimes someone who has a smaller practice has more time. Just go with your gut and see, find someone that can actually pay attention to you, and then also be your own patient advocate.
Correct. And, the problem is with the field of OBGYN, we almost go through 2 residencies, but combined. So it's OB, which is delivering babies, and gynecology. So majority of doctors in the OBGYN field are more involved with the obstetrics part and
sense.
Pregnancy. If I had to guess, I would tell you maybe 10 or 20% of us do like GYN also.
Can you also make it clear to them the difference between like OBGYN and gynecologists?
So OBGYN in residency, we get trained in obstetrics, which is delivering and taking care of pregnant moms and delivering them, and gynecology, which is women's health.
Okay.
So endometriosis falls into the GYN part of it. If you think you have endometriosis and you're trying to find a doctor, it's good to find OBGYNs or just gynecologists that don't do OB, or OBGYNs like myself that do a lot of GYN also, that have an interest in GYN. If you go to a doctor that their practice is 99% OB and delivery, you're probably not going to get the time and care you need with endometriosis. So it's good to do a search, not for this, for any kind of medical condition, so it's good to go to the specialist for that problem.
Thank you so much.
No
this was a great, I even learned a lot. This is amazing. So this is Dr. Aliabadi. I'll put her info on the bottom of this video if you guys want to reach her work. And people, you have an Instagram that you're going to start posting more. I know. What is it?
On the spot. Dr. What is it? Dr. Thais Aliabadi? No, is it the .com?
She's busy actually delivering babies.
It's Instagram.com? No, there you go. Then don't ask.
So cute. We're going to put it across the screen. It's okay.
Okay, good.
All right, guys. I'll see you next time.